Hello everyone, this is Sarah, your volunteer coordinator with Faith and Hope Hospice. This is going to be your training for this month of March. The topic is going to be on the dying process. Usually we record our trainings at the office with volunteers and we try to make it as interactive as possible. But because of the current situation of COVID-19, I'm currently working from home. So I'm going to be recording this solo. And Reid Jacobs, unfortunately, my wonderful colleague, will not be joining me, but he will be behind the scenes making sure that this is posted on our YouTube channel, which we will give you guys the link, of course, for you guys to listen to at your convenience. And I hope that, it really helps explain more a bit about hospice and the certain signs and symptoms that you're going to be noticing with your patients. I know not everybody is seeing patients right now, or you haven't started seeing patients. So I think that this would be definitely a good time to not only listen to this training, but perhaps go back to the previous trainings and kind of brush up on anything that you have questions about on those trainings, or kind of just to refresh your memories of what we talked about. And so once we start seeing patients again, hopefully within a couple of months, we'll be ready to go. And I would like everybody, if you could, to put in the comment section below if you could write questions and comments about, anything that we talk about today in the presentation. If there's any sort of situations that you've come across that this stuff reminds you of, that you can talk to us about, and so we can all learn together. So let's go ahead and get started. Like I said, the topic is going to be on the dying process. So a general overview of what we're going to be talking about. I'm going to go over the general criteria for hospice care, some of the signs of movement towards dying, the physical signs of transitions towards dying, and I also put it in different time periods. So 1 to 3 months, 1 to 3 weeks, and 1 to 3 hours of when the patient is most likely going to pass away. And at the end, we'll kind of do a wrap up and do how to care for and support for the dying patient, just little things that we'll go over later. So for the general criteria, I know I've talked about this before, most likely in your interviews I've had with you guys or during your orientation, about how does somebody become eligible for hospice? Well, this is going to be your answer. So a physician must be willing to state that the patient is terminal in 6 months or less. And as we all know, this is not an exact science. Nobody knows exactly when a patient is going to pass away. But this is the main criteria that people follow as a general rule of thumb. And of course, making sure that the patient does, of course, have an end-of-life diagnosis as well. The patient, family, or the MDPOA, which stands for the Medical Durable Power of Attorney, does not want to pursue further treatment, or all treatment options have been exhausted or declined by the patient, and there's measurable decline in the patient's condition, i.e. weight loss, falls, infections, more assistance with ADLs, which are activities of daily living. And every time we have a patient admitted with us, and every benefit period, which is, I think I've talked to you about this before, it's the first 2 benefit periods are every 90 days, and every period after that is going to be every 60 days. Which actually goes by pretty fast, but every benefit period and admission, we always try to identify the goal of care. So what sort of 3 main concerns that the patient and or the family members want us to address and look towards and try to maintain while the patient is under our care. So next slide would be 1 to 3 months. So these are we're gonna start jumping into just some sort of signs and symptoms that you could possibly see when the patient is 1 to 3 months away from passing away. So the first one I put is sleeping more, which is pretty self-explanatory. It just means that the patient may spend an increasing amount of time sleeping, or they could be awake and just appear to be uncommunicative and unresponsive. And this is all due to changes in the metabolism of the body. And what you can do if you have a patient who you are noticing once you start visiting that they're starting to become more sleeping every time you go, is still check in with the patient, identify yourself by name, and speak more in your normal voice, sometimes even a gentler voice depending on what's going on with the patient. And it's okay if they don't wake up. I always say just go in there, check in with them. And if they're unresponsive or they're sleeping, just tell them, I'm going to go check in with other patients. I will come back later to visit with you, or just sit with them quietly, if maybe for, I don't know, sometimes 15 to 30 minutes. Play some nice music if you'd like, kind of make a gentle, smoothing atmosphere for them. And just also remember, too, that just because they aren't communicating with us doesn't mean that they don't know we're there or they cannot hear us. They most likely can hear us, and everything we say, not just to the patient, but about the patient. So if we're talking to family members about the patient, if we're talking to staff members about the patient when they're asleep, doesn't mean they can't hear us. So always just kind of be aware of what you're stating around them as well. So another sign would be withdrawing, and that's a very normal part of the end of life process. So withdrawing from friends, family, staff, just anybody in their surrounding world, just because they would like to spend more time by themselves, or just have a bit more quiet versus having to talk and communicate as me and you communicate. And it kind of helps them to sort of start to detach from the relationships that they have in their lives, whether they're doing it subconsciously or unsubconsciously. It's something that we do notice a lot, that they do start to withdraw. And something that the volunteers can do is just make sure that you respect that, provide opportunities for them to be alone while maintaining their safety, of course. If you notice signs of somebody who's going to have harm to themselves or others, of course, we wouldn't want to leave them alone. But if they're just like, you know what, I'm tired today, I just kind of want to be by myself right now, that's more than okay. And then just tell them specifically that you're there just to spend time with them. If they don't want to, that's okay. And then let them know when you'll be returning, and let them know if they need anything in the meantime before you go. You could do that for them as well. The next sign would be appetite. And of course, we don't have our volunteers feed or give patients any liquids, but this is just another sign for you to look out for, that you'll definitely see a decrease in appetite and thirst. So wanting little or no food or fluids, which can be really hard, especially for the family members and whoever they have as their support team, because we know that once we see a decrease in appetite, we know that they are starting to decline. And it's something where we know as human beings, we need food and water to sustain, our lives. And so it's hard to know somebody's going to pass away and knowing that there's not too much we can do about it. So what we can do is, as family members or talking to the patients as volunteers, just asking them what sort of foods do they like, or what did they like, what's something that, or ask them maybe why they are no longer wanting to eat or drink. Just talking to them about their feelings, how they're feeling, but just making sure that you're using certain language where you're not making them feel guilty or trying to persuade them to eat or drink and tell them, oh, it's good for you, that kind of stuff, because we're letting the patient guide the way. So we're just making sure that, if that's the way their body is going to be from now on and that's how they want, then they'll let you know also when they're hungry or thirsty regardless. So that's something just to be aware of. The next step would be fatigue and weakness, which can also be a great source of discomfort for the patient, depending on how the fatigue and weakness is presenting itself. Because their energy is so limited, they're not gonna sometimes have enough energy to even have really full-on conversations. A lot of times we have patients who are fully alert and they're aware of what's happening to them, and they know they're no longer able to get up and simply go to the bathroom, go get a glass of water. And it can be really hard to comprehend that, especially when they're weak. It could be a great potential for a fall risk. And so we have to be careful about that also. So I would definitely say, as a volunteer, if they're feeling that way, definitely respect it. And just if they're open to you just sitting with them versus doing an activity or talking to them, that's more than okay as well. And just ask them, well, what would you like to do today? Instead of, we don't have to talk if we don't want to, but I would love to sit here if you don't mind, and just keep you company. Okay, so next one would be 1 to 3 days. So one of the first ones is vision-like experiences. So where you start noticing that the patient starts to speak to loved ones that have already passed away. They're seeing people who, aren't there in the room. They're talking about being in different places. And sometimes too, they might hallucinate. And a lot of that time, it's because they are going to pass away soon. But it depends, it's going to look different for a patient who has stage 4 lung cancer or congestive heart failure versus somebody who has end-stage Alzheimer's disease. Because obviously, if Alzheimer's, they're going to be seeing things and talking to people who aren't there already. So that's not necessarily, oh, they're going to pass away soon. It's just more of their normal. So if this is more out of their normal, then that's definitely a sign usually that they're going to pass away soon within the week or the next couple weeks. And so if you're there when a patient is doing this, it's important to not contradict them, not tell them, oh, this isn't real, because to them it's very real. So just really to confirm and affirm their experiences and asking them what they see, if they're open to talking about it, and just helping them remain calm. Because if you tend to argue with them, and I've been in that situation where I wasn't arguing with them, but I've seen the wife and the husband start arguing because the wife has dementia and she's telling him things that aren't true and he's just arguing with her. But it's like, we had to talk to him about it, like, to her it is very real. So we have to make sure that we're not making her agitated, because we don't want her to be agitated. We want her to be as comfortable as possible. So just educating yourself and, the family members around you, that could really be helpful. Another sign would be fever and chills. So as the body becomes weaker, so does the temperature control mechanism in their brains. Because as they become weaker, their circulation also decreases, which makes them cooler to the touch. Or they can be really hot, right? And which could also lead to discomfort. So I would say definitely as volunteers, what you can do is, if you're in a room with a window or a fan, open the window a little bit, crack it open, turn the fan on, sometimes even getting a cool washcloth and putting on their foreheads, removing blankets that don't need to be there, especially if they're becoming restless. It really helps to kind of just make them more comfortable. And those are little things you can do as well. Disorientation is another one, which means that they are confused about the time, place, and identity of the people surrounding him or her. And that's a lot to do with the metabolic changes that are going on in their bodies. So the best thing you can do is, especially if you built a good rapport with them and you know who they are, would just be to identify yourself, and so they can remember you, or they might not remember your face or your name, but they might recognize your voice. And just even in general, just speaking softly and clearly when you're communicating with them could really help, so they don't feel get agitated or anything like that. Incontinence is another one. The person may lose control of their bladder, their bowel functions, because their muscles begin to relax. And there's not too much that volunteers can do about this one. That's just a sign that is really big amongst patients that are going to pass away soon. So I would say if you notice that, then to just let the staff know, or just let their family members know, especially if it's leading to their agitation and in the current moment of when you're visiting them. Another one would be physical restlessness. So that can show up as repetitive motions. If they're just moving around a lot, they're kind of playing with the clothes that they're wearing, or the bed linen, or they're moving their hands in repetitive motions, or they're finding comfort in holding on to certain objects. That usually happens because of the decrease in the oxygen circulation to the brain, and of course to the body's metabolic changes as well. So the best thing you can do then is just to remain calm, speak in a quiet, natural way, sometimes lightly massaging the forehead, playing soothing music, reading to the person. You can read books or poetry. Sometimes patients have journals that they've written a long time ago. Maybe you're reading that to them. Or there's even such things like guided meditations that you can read, and that helps create more of a soothing atmosphere as well. Another thing would be breathing pattern changes. This is a really big one. One common pattern consists of irregular breaths. So shallow breaths and then periods of no breathing for 5 to 30 seconds or more, which can be it's a little disconcerting, especially when you're not used to it or you're witnessing it for the first time, and you might be visiting a patient and not realizing that they're starting to decline, but then you might notice these little things and you're like, oh, okay. And it can be scary because it looks like they're not breathing for a little bit, and all of a sudden they take a big gaps of air or just start breathing all more shallow all over again, and it can be hard to watch sometimes. And so the best thing that makes the patient most comfortable is kind of elevating the head of the bed and or turning the person on their side to help them breathe easier. But of course, our volunteers can't do the physical stuff like move them like that. So I would definitely say if you're with a patient by yourself at a facility or even in their home and there's family around, they're just not in the room with you or their staff, just let them know. And then just report it to hospice staff, especially if we don't have a nurse there already, which most cases, if we know the patient's going to pass away soon, then we would have a nurse there 24/7 because we increase their level of care. But if there isn't and we haven't noticed yet of what's going on, please let us know right away. So the next slide is days to hours that the patient is going to pass away. So one of the main signs is a surge of energy, which is going to be very short in duration, and it could be for different stuff. It could just be for one last family gathering. It could be to have that conversation with somebody. It could be one day they're just feeling a little bit better without really knowing why, and it's usually because of this reason. Sometimes it's because they have something that they want to resolve, and they know their time is coming to an end, and they just want to be there for whatever reason. And if you're there when that happens, just don't really talk about, I would say, oh, like you're doing so much better, or oh, like you were this yesterday and now you're feeling better, what happened? Because most likely it gives a false impression that they're getting better when they're really not. So I'll say focus on the positive and just enjoy the time for what it is and reminisce together and just talk about happy stuff just to keep their spirits up. Another one would be urine decrease, and you might notice, especially for patients who have catheters, because you can see the bags usually too on the side of their beds when you go visit with them. You might notice that their output is not as much as it used to be. It decreases, and that's for usually because the fluid intake has decreased, and there's also a decrease in the circulation of the kidneys. Another one would be mental, spiritual restlessness. And it kind of goes back to what we talked a little about before about the physical restlessness. But this one would be more due to emotional or spiritual or mental discomfort, mainly to maybe they feel like they have to resolve something. Maybe they are on the outs with some of their family members or something, and you're there and you know that the family's in visits and you know that they want to make amends. Maybe helping them reach out to their families and making amends, because it could really help them find that peace and know that they're ready to go. And even the volunteers and giving assurance that it's okay to let go and providing examples of how you're going to be okay without them, and maybe giving them examples of how they made a difference in the world to really help bring peace to their sense of mind. Which brings us to the last point, which is giving permission of saying goodbye, which can be really, really hard, especially with patients you've developed a really good relationship with, but not many people get a chance to say goodbye at the end. And it's really something that could help achieve closure for the patient and or the family members and the volunteers, and just making sure that you're giving them that gift to let go of the burdens they're feeling or any guilt that they might be holding on to, and that it's okay for them to go, and it's okay to show emotion too. It can be very emotional time, so just being there presently with the patient and our family members and being able to display that emotion is actually very, very real and very important, and that's more than okay. So for the next slide, I put a transition continues, and there's a little bit more about the physical stuff that you could notice about patients who are going to pass away soon. The skin may appear yellow or gray. They could have a high fever. I talked about the rapid breathing. Sometimes too, they get like a gurgling in their throat, which it sounds like a deep rattle. It's like every time they take a breath, it sounds like they're gurgling, and that's a really big sign as well. The respirations become rapid and shallow. Sometimes they're awake and they're aware of what's going on. Other times they're non-responsive and they're unconscious. So it really just depends on what's going on. The next slide is care and support recap. First one I put was respect the patient's wishes, which is something so important that definitely volunteers play a huge part in, is making sure that their wishes are respected and their dignity is maintained. And whatever it is, even if it's something that we don't know if we would do that for ourselves, or it's something like, hey, I know they want this, but I don't know how to make it happen, reach out to me, to Reid, let us know what's going on. And so we're able to make sure that they get the best care possible. And the next one, for the mouth swabs to keep the patient's mouth moist and clean, we wouldn't have our volunteers do that, but that's something that you might see, if especially when the patient's towards the end of life, that the family members or the staff is definitely gonna help them with, to keep them more comfortable. A cool washcloth, we talked about that, putting on their foreheads to help with their restlessness, or if they have a fever or something. Covering the patient with a sheet or a blanket if the patient feels cold. Keeping the immediate environment quiet and restful, which can be something definitely that you guys could do. Just even dimming the lights and just keeping it calm, and meditation music or something, if the patient's open to it. I've been in situations too where I've been with patients who are in pain, and you're trying to figure out what you can do to help them feel better, and it can be a very powerless feeling because you want to help, but there's only so much you can do. And not everybody likes meditation music. Not everybody likes soothing atmospheres. Sometimes they want you just to talk to them, just to distract them. So it just depends on the patient and the situation. Speaking quietly, hearing becomes more acute in the dying patient. And that's something we talked about earlier, because like we said, we don't know what the patient can hear. So just being sensitive and aware of what you're saying, and being self-aware of, and being aware of the surroundings of everything, that's super important. And last but not least, report to the volunteer coordinator or hospice staff any noticeable changes during your visits. And I can't emphasize that one enough, because it's a lot of times our staff visits on certain days, but a lot of times the volunteers are visiting in between those days. So there's going to be things that you may come across that have changed that we don't know about, and you wouldn't know about because you're not seeing the patients on the days the staff visits. And it could seem really small and insignificant, but sometimes I've seen your guys' notes and I read them and I'm like, oh, hey, I didn't know this. And I asked the coordinator, hey, did you know this about this patient? This is going on. And they're like, no, I didn't know that. And then, hey, that's something we could address. So that's something that's super important to put in your guys' clinical notes. And we do read them, and documentation is super important. What we say, as in the social work field, in the nursing field, it just mainly just saying that if you didn't document it, it didn't happen. So if you guys don't document what's going on with your patients in the system, then technically in the Medicare's eyes, like, the visit never happened. So we need to make sure that you guys are getting credit where credit is due, and making sure, most importantly, that the patient is getting the care that they need. So please, please, please document everything that you do with your patients, and little signs that you're seeing, that how they're feeling, how they're looking to you. And if you have any questions, please let me know. Okay, so for the last slide, for wrapping it up, to tie everything together, death as we know it comes in many different forms, and that's so true. We can have patients who both have end-stage Alzheimer's, and I think I've had one patient who had that diagnosis, who's actually very aware of everything until the very end, which you don't see very often, and that one surprised me. So that it just goes to show you, people are very resilient, and our patients are super strong and important, and it just, you don't know who's going to handle what. So it's very important that we treat everybody as individuals. Every person exhibits different behaviors during the end-of-life crisis. Identifying a specific stage can help you determine where the patient is, and it can help not only us, but it can help the families and their support systems know what's happening to their loved one also. And so if that's something where you have good rapport with the families, and you guys kind of talk about it and it comes up naturally, then that could be something that even you guys could educate them on, and just kind of help them learn more about what's going on with their loved ones. Okay, well, that brings us to the end of our training for today. And like I said before, earlier before we began, if you could comment down in the comments below about any like questions or suggestions or anything that I kind of breezed over that you want to go more in depth with, even if you have ideas or certain interests in what topics you want me and Reid to go over more for next month's training. If you have any suggestions, if you have any scenarios or anything that you guys have done right or wrong, that you want to, share with everybody, I'd be more than happy to encourage this. I would love that, just to make this as interactive as possible. And I hope everybody stays safe out there. I know it's kind of scary what's going on right now, but the best thing we can do is just remain washing our hands, keeping vigilant about infection control. And if you guys need more information about how hospice is responding to all this and how we're changing our procedures, or if you have any questions or anything like that, please reach out to me or Reid. You can reach us on our email addresses and we'll get back to you guys. So thanks again for tuning in and take care.